What is the most underrated, low stress, legit great specialty out there? Well, what if I told you, in my opinion, that it's occupational medicine? You probably did not expect that. And if you've ever had to deal with occupational medicine cases in like family practice, urgent care, or the ER, you're probably groaning right now or rolling your eyes thinking, occupational medicine is awful. But I urge you to watch this video to the end. I think you'll be convinced that I'm right, or at least that it's a better specialty than you think. Today, I'm joined by Shaun Lynch. He's a PA with over 10 years of experience in occupational medicine. Plus, I'll share some of my experiences working as a PRN PA in a soft drink bottling facility. So welcome, Shaun.
Thank you, Michelle, for having me. I'm excited and convince some of those people out there that this is a really great specialty to consider as a clinician.
So first of all, tell us a little bit about your journey to becoming a PA in occupational medicine, like how you landed in this field and kind of what drew you to it.
I spent 3 years working in the emergency department. And after those 3 years, unfortunately, I kind of hit the wall and started dealing with a little bit of burnout. And I decided to make a move. My family decided to make a move, actually. And we packed up from North Carolina and moved out west to Denver, Colorado, kind of on a whim. And it was from there where I actually not only got a job starting in academics, which I've been doing ever since the majority of my time, but also I had an opportunity to work in occupational medicine as well. It kind of nothing I was really seeking to do, but it was a chance for me to work in an urgent care setting that predominantly does occupational medicine. So after working in the Denver market with the same company for a few years, kind of covering at about 15 different centers, we decided to move back to North Carolina to be closer to family, but also to continue my academic work. And fortunately, I was able to continue working in occupational medicine with the same company. And I've been in this market for the last 9 years, covering about 4 different clinics.
That sounds great. And it also shows the flexibility that you can also find in occupational medicine. You can do it full time. You can do it PRN like I do. You can find part-time work. Almost like urgent care, you can find a very flexible schedule, right, in this specialty. And another thing to point out is that there are a lot of nationwide occupational medicine companies. And so, like you said, you were able to transfer working for the same company, like different states. And so I think that's a great thing for people to think about if they know that there might be a move coming up in their future. A lot of the occupational medicine companies are nationwide, probably more so, I would think, than many other types of institutions. The occupational medicine company that I do PRN work for, I know they're all over. So that's a great way to be able to set yourself up to stay with the same company, keep all your seniority and benefits and all that stuff, and just transfer wherever you're going to move to. And we're going to talk a lot throughout this interview about the different ways to work in occupational medicine. So you have traditionally worked in the type of occupational medicine that's an urgent care / occupational medicine, right? Yep. So in the setting that you work in, do you guys only see the urgent care stuff for companies that are contracted with your company to handle their occupational medicine, or do you see anyone from the general public, but then you also see occupational medicine?
So our urgent care actually is open to everyone. They say urgent care, but 90% of the patients we see and services we do is actually occupational medicine. So we do see some urgent care. It can vary based on the season. It could be a couple of patients a day, but the majority of the patient volume that we deal with is occupational health.
Can you give us an idea of what kind of, like, the variety of cases that you see for occupational health? What are the majority of people coming in for?
When you think of work-related care and things like that, obviously you're going to expect to see a lot of musculoskeletal complaints, right? As serious as a fracture, sometimes a dislocation, and then, of course, a lot of strains and sprains and tendinopathies. But what's interesting, though, is not just the musculoskeletal component. We actually do see a lot of certainly some lacerations, crush injuries. We see a lot of contusions, burns. And then probably one of my least favorite things still after all these years is that we do see a lot of eye-related complaints as well due to occupational injuries and exposures, things like foreign bodies, corneal abrasions, chemical exposures, and then also some things you might not think about that you would be as common. And these can be things like noise-related issues, loud, either repetition or something loud that would rupture a eardrum, dermatitis, some kind of funky skin reactions, and also some things like inhalation. They're around some certain chemicals. So you see why I like it. It's a big variety of certain things that we get to do.
And usually the patient population is relatively healthy and they're pretty much adults, right? I don't know if the other urgent care part, but for at least the occupational side, which you said is the majority of what you see, we're really talking usually people between like 18 and 65-ish. And you're not normally dealing with all their chronic stuff. You're really seeing that really acute stuff. You're not wading into the weeds usually about their whole medical background, right? You're dealing with that component, and then they move on. Or you may see them back for follow-up, but it's not the same as chronic care.
Well, you nailed it, right? And I'm an acute care guy. I like to be able to fix the problem ideally right away or within, a few weeks of the patients coming back in. So I think there's a big draw for people that's really kind of into that kind of patient population.
Do you guys do other things like physicals, work physicals and stuff?
Yeah, we do a lot of that as well. We do a lot of pre-placement physicals. You're kind of going through their medical history with the patient. You're doing a really good physical exam and making sure that they are fit for duty, so to speak, and they don't have any limitations that would keep them from doing the job that they're seeking. So this can be from a wide variety of different types of jobs. We also do a lot of what's called respirator physicals. So we medically clear patients that need to be wearing like the big either full face or half face respirator mask. Sometimes even just wearing an N95. We see a lot of kind of, I call them the transient healthcare workers that's doing travel work. So we do a lot of those as well. And we do a fair share of what's called medical surveillance exams. So this is where you may have a worker that every year or two, they come in, they do a kind of a symptom screen based on the nature of their work. They update their medical history. And think about this is the person that might be working around certain environmental, chemicals or things, asbestos, silica. And sometimes there might be some ancillary testing on top of that. They might do a hearing test, an audiogram, or even spirometry to kind of measure lung function as well. And then I'd say finally, one of the biggest things that we do from a physical standpoint is we do a lot of DOT, Department of Transportation, physical exams. So that right there is a kind of a big variety and snapshot of the things that we get to do.
And I know a lot of people talk about the DOT exams and are not sure if they want to do that. What are your thoughts on doing DOT physicals and what are the kind of pros and cons of doing that kind of work?
Basically, your job with the driver is to kind of go through and make sure that based on their medical history that they are kind of meeting certain standards to be safe to operate a commercial motor vehicle. So you do have to undergo some training and a certification test for that to be registered through the Federal Motor Carrier Safety Administration. But also you can do a lot of screening in these exams as well. And to give you just a quick example, we do a lot of screening for sleep apnea. Sometimes we can catch a lot of that. Sometimes I get a new onset patient with diabetes or glycosuria in the urine. Their blood pressure may be out of control. So, I'd say the pros of it are you get to really kind of help with their care. The challenge with it is sometimes is that the driver can give you a lot of pushback for having to do some further things to get certified.
And it's their livelihood. So if you're in the position where you have to tell a driver that, like you're not on probation, but they have like a certain time period, right, where they have to usually fix something. And if they don't, they could lose their license. So I think that's where some people are worried that that's a big problem. But Do you find that that's a big problem, or is it not as big as some people think?
I don't think it's as big as some people think. I think a lot of it's how you frame the conversation with the driver, right? I think that's part of it. And you're right. Sometimes you have to what's called pin the driver to get information, maybe from their doctor, or if they've had a cardiac event, they have to sign off. There's certain guidelines that the DOT kind of provides the medical examiner, which is you, the clinician, to be able to go through. But early on, I got a lot of pushback from drivers. But yeah, I think you learn with time and experience to try to finesse those conversations a little bit and really try to drive it into the driver, the importance of doing so. And I try to be very cautious and empathetic with the driver and recognizing that I do want them to be able to continue to work in their livelihood. But when you frame it, you don't want that on your conscience to be able to fall asleep at the wheel and then cause a bad accident and maybe harm someone, right?
Yeah. It can be a challenge sometimes, and even just in occupational medicine in general, when you're dealing with people with work injuries. I would say in my experience that most people are pretty genuinely interested in getting better and not trying to, milk the system and all that stuff.
Okay.
But I know that's another thing that people think, well, I don't want to deal with occupational medicine because all these people are just trying to, get free money and not work. What do you have to say about that? What's been your experience?
Honestly, Michelle, that's probably one of the greatest misconceptions I think people have about occupational medicine. And I remember when I first went in, I felt that the same way. Look, I'm coming from an environment in the emergency room. I remember one time even sitting in triage getting a chief complaint for a work note, right? So it was a complete and total shift for me when I first started doing this kind of work. But in my experience, generally, most people do want to go back to work. And they're not really, there's only a very small subset that I feel like are trying to, I don't know, what you call game the system, so to speak.
Yeah.
So I think overall that the majority of people are just really want to get back out there to be able to provide for their family and things like that.
Yeah, that's been my experience as well. I mean, there's some that you're kind of like, but usually you can tell with your physical exam. I mean, you do it long enough, you really know when there's proof and when there's not. And sometimes I
Yep.
feel like I just got to give people the benefit of the doubt for a while. But that was another thing, I guess, that when I first started in occupational medicine, that I didn't understand, like ongoing cases, that they would just keep coming in for a checkup and nothing was moving forward, nothing was happening. The employer's like, what's going on? For people who don't know, do you just have people who aren't getting better just going to be seeing you forever, or how does that get resolved?
Ideally, I would say that 90% of our cases are temporary, right? We call them temporary disability cases where maybe they just need some restrictions for work for just a few weeks till they get better. So we'll see patients for the initial injury. We see them back in follow-up for what we call rechecks. And that generally will be for a few weeks and doing a different trial of things to get better. Maybe that's physical therapy, medication, restrictions. And then what's really great about, at least in the market that I'm in now, is that if I need to refer the patient to a specialist for any reason whatsoever, as soon as they get scheduled with a specialist, the specialist will take over care so they don't have to come back and see us. Now, when I was working in the Colorado market, we did see patients back in follow-up, even if they saw the specialist up to a certain point. And we had physicians in the group, and we kind of called them the closer, right? So it's like you go to the bullpen, you're signaling them in. And these are for those cases, those small cases where the patient's just not getting any better. They've tried everything. And then maybe they determine that maybe they need what's called a functional capacity exam to see how much work they can really do. Maybe they have some impairment that's going to be permanent. That's where they break out, the goniometers and all those fancy tools and things like that. So again, those are small subset of cases.
There is a system in place where there is somebody that makes that final determination. And it's usually not a PA or an NP, right? So that's kind of
Right.
actually nice because the final thing doesn't fall on your shoulders.
And just one thing to quickly piggyback on that is, we try to set expectations right from the first visit. A patient may not completely be pain-free when we're done with them, so to speak, when we release them back to either full duty And we try to set expectations. My job as the clinician is to get you as close to functionally to your baseline as possible. And that's ultimately the goal. So we really try to emphasize function and document that at every visit.
And I think that the other thing that people might balk about, especially like I said, if people have seen some occupational medicine in family practice or in their urgent care or emergency medicine, and they've got some forms they got to fill out, and they're like, this paperwork seems crazy. In my experience, once you do it regularly, it's fairly easy paperwork. Can you speak to that a little bit?
I joke with my colleagues that, we are, one of the things that we do is we push a lot of paperwork. I can't tell you how many times a day I have to sign my name to different forms and things like that. And that's just the nature of this kind of work. I will say, though, that at least in my experience with the company I'm with, we try to do as much as we can to streamline a lot of that stuff through our electronic medical record system. Mm-hmm. We have kind of templates set up for, I call it the art of writing work restrictions. Now, keep in mind that when you have patients coming in for pre-employment physicals, and they might have their own paperwork to deal with in that case, and there can be a little bit of time consumption with the paperwork and things like that.
Yes, it's a lot of paperwork, but when you only experience it every once in a while from whatever setting you're in, it seems overwhelming. But when you do it all the time, and like you said, you guys have processes, things are streamlined. Where I work, it's streamlined. The documentation system is actually very easy, the one that I work with. And you get used to filling out the forms, and so they go pretty fast.
Yeah,
so it's not,
I would agree.
I mean, no one likes paperwork, but it's not as overwhelming as it may seem.
I think probably the biggest challenge of everything working in occupational medicine is this thing called the OSHA recordability. And this is something that some employers are very sensitive about. So for a quick overview for you, the listeners, this is something where if a worker experiences an injury and you have to administer care at a higher level than what's called first aid, then it gets recorded for the employer. So some employers are very sensitive about that. And sometimes in conversations with you when they're sending a worker in, will kind of remind you they want you to be OSHA sensitive. So you got to kind of juggle that sometimes, balance obviously doing what's best for the patient, but also trying to be somewhat sensitive to the employer as well.
I may experience that maybe even a little bit more than you do, because I work specifically at the manufacturing facility. And so I'm at the employer's work site. We have a clinic within their facility. And so when someone gets hurt, especially if it's something like a laceration or something that they think might become recordable, they usually come down, with the patient. Yep. And they're trying to remind you. And so I remember one time I had a patient had a laceration right here. It was a very clean laceration, but it was a pretty good slash. And so immediately I'm thinking, oh, I'm going to have to suture that, especially because, there's so much movement right there. And of course, the employer representative is like, no, you don't, can't you just put a Band-Aid on that or something? And I'm like, no, I can't put a Band-Aid. But she did make me think a little bit. And she's like, can you, because there's certain things like steri strips, right, fall into non-recordable, whereas wound glue or sutures falls into the recordable category. And so I said, well, let me see. And so I worked on stopping the bleeding and cleaned the wound, and it looked, pretty nice. And I thought, maybe. So I was still leery about it, but I put steri strips across it. Like I steri stripped the heck out of it. And then I put a big bandage over it. And the great thing is with occupational medicine, especially when you're on site like I am, is you have great follow-up. They're going to come back tomorrow no matter what, because that's their place of employment. And so I just, gave them a lot of cautions about try not to use that hand very much for the first 24 hours because it might break open. And he was happy because he didn't have to have sutures. and so he's like, sure, I'll baby it. Came back the next day. I wasn't there because I was working PRN, but I talked to the PA later who took care of him, and I was a little nervous. I was like, did it break open, or how was that laceration? She said it healed beautifully. And I'm like, what do you know? Because I would have numbed the guy up and thrown sutures in. So, I mean, it's a pain in the butt sometimes, and it's really annoying to have somebody kind of, over your shoulder telling you what they want you to do for treatment when they're not medical. But on the other hand, it does keep you from over-treating sometimes when you don't necessarily have to. So there's kind of that balance there. So I'm on site with the employer, so I'm always talking to the employer. But when you work at a company like you do, are you ever directly in contact with employers?
Yeah, actually, we are in a couple of ways. So the first touch point we have is sometimes an employer will give us a call to give us a heads up about sending a patient in, especially if it's kind of an interesting story. They're not really sure what happened and try to give us a little bit of context and background. Another situation is sometimes the employer will actually come in with the patient. We see this a lot with certainly wounds, lacerations, and things like that, but that is not super common. One thing that we are encouraged to do is after each initial injury visit, we have a contact where we try to give them a courtesy call to, hey, we saw an injured worker, just to kind of give them just a quick update on the injury and just the kind of the plan of care that we're going to go with.
And do you ever find it challenging to walk that line between HIPAA and then what the employer needs to know or should know?
That's a good point. And one of the things that we do, at least in our output for the medical documentation for an injury visit, especially in particular, is that the employer only gets the assessment and plans. We have to be very careful not to kind of list anything maybe in their past medical history that could be disclosed to their employer that's not relevant to their injury or their illness. So I think that's certainly always in our mind when we're kind of doing our documentation, especially when we're writing kind of our medical decision-making component of our documentation.
I'm curious about like autonomy there where you practice. Is it all PAs and NPs, or do you have physicians on site?
One of the things I've enjoyed probably the most in my setting in both Colorado and in North Carolina is I've had a lot of autonomy in my role. So a physician on site, it depends on the day. The company tries to at least staff a clinic with a physician on site, ideally. Now, as you can imagine, that's not always the case. So that can depend on the day, but generally you have high day-to-day autonomy. But you do have a collaborative physician support if something comes up that you need something or you need to run something by for it, whether it's an escalation for a red flag or maybe even a referral that you're kind of on the fence about. Maybe you have a DOT driver that you're kind of unsure about and you want some guidance on how to handle a certain case or a certain situation. So those are instances where you would have a physician potentially that you could reach out to. And our company's very good about that. But honestly, there's many days where it is just PAs and NPs in the clinics, depending on the setting and where you're at.
And like for me at this on-site clinic, it's only PA or NP, and there's a 7 a.m. to 3:30 shift and then a 3:30 to midnight shift. And it's Monday through Friday, so no weekends. But I know that varies greatly. What kind of hours is your urgent care open? Are you guys open on the weekends? Do you do evenings or overnights at all?
Generally, in our market here is just normal business hours, Monday through Friday. This ranges anywhere from 7:30 to 5. Occasionally, in some areas of the country, there's limited Saturday and Sunday hours, depending on how busy the area is and, again, the market. So there's some differences there. I do know our company has, especially in our West Coast centers, they do a lot of 24-hour centers as well. So they do a lot of overnights, especially if they're in an area with a lot of companies around where they're working round the clock and injuries can happen, like you said, third shift or second shift and things like that. And one of the great things about it is there's no call, at least with our company in this setting. And generally you can avoid, weekends and holidays, which is a good thing.
And unlike family practice, they don't have like a lot of labs and things you're always doing. I mean, you may do labs for somebody, but it's not an ongoing thing like family practice where you're always thinking about what needs to be done. Usually, when you get done the day, you're done. We've talked about some of the things, but what are the things that you love about occupational medicine the most?
I think for me, it's about restoring someone's function and livelihood and not just, treating the diagnosis. Work is more than, a paycheck. Think about our jobs and how much it shapes our identity, our routines, and for me, our sense of contribution. So I think it provides a structure for somebody, a social connection and kind of a reason for them to kind of sometimes get up and get through the day and how they provide for their family. So I think it's really rewarding to be able to take someone that's been injured or had an illness and be able to give them kind of the confidence to get back into the environment to where they can do some of those things.
The great thing about occupational medicine and why I recommend it so much is because of the variety of places that you can work in. And I'm going to have you talk about that a little bit more in a minute. When you're working at an on-site, often it's called like corporate health or things like that. And there's a ton of these. Like I said, I'm in a soda bottling factory. My friend used to work up at Hanford Labs up in Washington State. So working with a lot of scientists and people like that. They have their own on-site thing. And then different aerospace companies, meat packing factories, like anything. There's tons of them around the country. And people, I don't think even healthcare providers realize that there's so many on-site clinics. And when you work in an on-site clinic, you have a certain population that you're seeing. And so you have that continuity and that familiarity with them. They're on site. Like I said, they don't have to leave their place of employment and drive and make an appointment to you. Follow-up is fantastic because they're right there. When it's workman's comp, they're not having to pay, the patient themselves are not having to pay for anything. So you can prescribe medicines and you can order things. Now, obviously, the insurance company for the employer has to approve things, but if it's reasonable and is what is to be expected, then that's usually not a problem. But also, the amount of time you get with employees when you are working at an on-site facility is generally much better than an outside facility like you're working at, just more like an urgent care type thing. How many patients do you guys normally see a day there?
I can see anywhere in an 8 or 9 hour shift, anywhere between probably 25 to 40. It just depends.
That's more on par with like a regular urgent care, that pace where you're seeing patients a lot. The place I'm at is very slow. There are many shifts I see 0 patients, which would drive some people nuts. I'm fine with that. But, on a typical day, we're probably seeing like 5 or 6 patients. We're doing hearing screenings. We're doing biometric screenings, kind of a snapshot of their health, and you counsel them about it a little bit, which I love to do all that preventative stuff. But if I need to spend 45 minutes, an hour and a half with my patient, then I can. It's not, a big deal. And that's what I love about it. And like I said, this place maybe, I'm sure, is on the slower end, but there are a lot of places that I have checked out before where you get 45 minutes with a patient and is not unheard of at all. And you have time to talk with people. And like I said, I don't like pediatrics. I don't really care for geriatrics because they're just really complicated a lot of times. And so I have that healthy population. So those are some things that I love about it and why I think it is one of those hidden gem specialties that people don't often think about. And so I'm curious, because you've been doing this for a long time, what kind of settings do people not realize or not think about they could work in occupational medicine?
Certainly, I think another large employer is a hospital-affiliated kind of occupational medicine urgent care centers. So these are sometimes under big healthcare systems. Certainly, a lot of manufacturing plants have on-site clinics, which I've done as well, and I thoroughly enjoy that because of all the time you get to spend with the patients, although it's a slower pace. Certainly, universities can have this as well. I've got a friend that he does kind of film work and more of the kind of staging crew things out in California, and they always have kind of on-site medical for, work-related injuries, especially if they're doing a lot of repetitive type of stuff, which they can tend to see. So that's certainly one option. I also have a family member that works for Disney. They actually have some occupational health stuff as well. Certainly sports organizations and things like that are some other ones that I can kind of think of that are pretty cool.
Yeah. And people I've interviewed that have done occupational medicine on like oil rigs or up in Alaska, at these really remote places, especially if you've got the great experience like you do of having some emergency medicine and you do urgent care a lot, they really like that, because when you're out in the middle of nowhere, somebody gets hurt, you need to know a little bit more than like if I'm just working at this bottling facility. If somebody comes in with something more than I can handle or have the supplies for, I just send them to the emergency room. But in those remote locations, they need people that can handle that stuff, but also understand just the occupational medicine side of the general injuries. So yeah, there's a lot of really unique opportunities in this field. In fact, the guy that I interviewed who worked at the South Pole Research Station, and
Oh, wow.
and
That's
down
cool.
there, yeah, in the polar winter, he talks about what it's like to live down there. But that's what they were doing, is they were handling, employee health. So
Yeah.
this field has so much variety. So if you like fast paced, in a situation like you're in, if you like that kind of environment, because some people thrive in that, you're not, again, in the weeds handling usually very complex medical stuff. Like you don't have an 80-year-old come in that you're worried if they're having, stroke or all these different things. It's usually more straightforward. Or the slower pace, like I have, you get to do preventative medicine, but then also help people, like you said, heal from injuries and get back to their livelihood and their work. And I just think it's a great mix, and often lower stress once you understand what it's like and understand the systems in place for it. Okay, so if somebody is watching this and they are going to be a new graduate, do you feel like this is something that a new graduate should or could step into, or do you feel like this is one of those specialties that really you should get some experience somewhere else and come into it?
Is it new grad friendly? I always say yes, but then I pause. And I think if you have very structured onboarding and mentorship, it can be, especially if you've done a couple of rotations in this setting towards the end of PA school. But ideally, depends on the clinic and the employer, especially if you're going to be solo, obviously. Probably not a good fit to start out with for the first year or two. You really want to kind of strengthen a lot of your kind of core foundational medicine, I think, your first year or two out. That's just my opinion.
And then how about people who are already working as a PA? What specialties do you think transfer easily over to occupational medicine or would be a good fit for people to move from into occupational medicine?
Probably the easiest transitions from people that's worked in, obviously, emergency medicine, orthopedics. Probably urgent care is as well. Those tend to be probably the best specialties to kind of easily make that transition. Now, we do get some primary care providers that come through, and some of them do pretty well. Some of them maybe struggle sometimes with the speed, but in my experience, providers that's kind of got that background do thrive and do very well.
Yeah, and I think it depends on the setting that you work in. You can find anything in the spectrum in occupational medicine. So I think it's important that people think about that and what they're good at, their skills and their weaknesses, and what would be the right kind of setting for them, because you can find it in occupational medicine pretty much if you look for it. If you're interested in exploring more medical specialties, then check out this playlist here. Thanks for joining me, and as always, take care, stay sane, and I'll see you next time on the Medicine Couch.